So with that in mind, VIP is my new friend. I have been looking at VIP since 2005. You will see the work of Mario Delgado all over VIP. Back in 1996, people recognized that this 26 amino acid peptide in the secretin family was neuromodulatory and immunomodulatory. It affects hormones. It looked like it should be a big deal when we finally had reliable data showing profound VIP deficiency was even more common than MSH deficiency in patients with these illnesses. So when I look at neuropeptides that interact with each other, and vasopressin with the MSH with VIP, vasoactive intestinal polypeptide, is the only one that has a huge literature that looks at what the different things that it does. And it turns out it has a great role reducing pulmonary artery systolic pressure. So in addition to binding to membrane receptors to raise intracellular cyclic AMP, it also downregulates cytokines. And for people that are exercising, it reduces the pressure between the right side of the heart and the lung. And if you think about it, if we want to increase left ventricular stroke volume, which we want to do in exercise, we've got to increase right ventricular stroke volume at the same time. And if right ventricular stroke volume is reduced, or the work to maintain that is increased in exercise, people will then have reduced left ventricular output. Remember, the cardiac output is stroke volume times pulse. And if we are dependent upon venous return from left atrium to left ventricle to enhance stroke volume, and we can't get that because of the rise of PA pressure that's dysfunctional, people will compensate with extra outcomes from pulse. So in your patients with tachycardia and funny palpitations with exercise, and shortness of breath with exercise, it might be obstructive lung disease, it might be bronchospasm, or it might be acquired pulmonary hypertension. So what we did is to look at what VIP might be able to do in a clinical trial where we took people whose entry criteria was low VIP and a history of elevated C4A and a history of elevated TGF-beta1 and a rise of PA pressure 8 millimeters of mercury more in a cardiac stress test. So we took them and gave them VIP 50 micrograms a dose 4 times a day. We were supplied the VIP by Hopkins and Drug. Dennis obtained it, made it for me, sent it in a bottle that gives a nice uniform dose most of the time, and it's one that should be kept refrigerated. People like me made some mistakes with VIP early on, and in fact, one of the first bottles I had personally, I took to a chronic fatigue meeting, put it in my briefcase, had the nice little nozzle caps screwed on as tight as we could do, and by the time I get to Reno, Nevada, I've got 2 doses left in my bottle because the seal, when it falls over the side, is not quite as good as what I want. Maybe I didn't screw it down tight enough. I don't know. But in any event, if you take the little bottle that you get from Hopkinton, cut off the little extra tube at the bottom, prime the pump, you can pretty much reliably give yourself 4 doses a day and get the same amount each time. At the end of a month of VIP, we looked at lab parameters, repeated pulmonary stress test measurements, showed benefit. We then reduced the dose to 2 sprays a day, and at 2 sprays a day for a month, we looked at symptoms, lab parameters, and pulmonary artery systolic pressure responses. And once again, we saw everything stayed fine, although early on, there were a number of people who felt much better on 4 doses a day compared to 2. And so what we did with them is say, forget the study. The third arm with that was to take you down to 1 spray a day and then go off. For everybody involved, we noted when did they decide to drop out, and then reinstituted VIP outside of the study and follow them now for a total of 1 year. What we've seen pretty routinely is that most people, after 6 months, can tolerate a reduced dose of VIP from 4 doses a day down to 2, down to 1, and for at least a third of my absolute very worst chronic fatigue patients, the ones for nothing had helped, they're refractory to everything, they're off medicines, and they're essentially cured. We will continue to follow them over time, but this is the first time in working in this field since 1997 that I've used this 4-letter word called cure. We know full well that if you use VIP and you have re-exposure to a water-damaged building especially, or you get another bout of Lyme disease, you're right back to square one. But the response that you have is tremendously truncated, and functionally people can go back into water-damaged buildings where before they would have been sick within 10 minutes. Now it takes much, much less, or much, much longer, excuse me, said the wrong thing. And similarly, people that used to have a rise of C4A from baseline 3,000 to 40,000 with an hour of exposure, now they'll go 3,000 to 5,000. So VIP does a lot. It downregulates MASP2. Remember, MASP2 is the enzyme that stimulates cleavage of C4.